Welcome back. Now, after finishing the first part and having an idea of different surgical incisions, let's go to the various incisions used in abdomen area. As there are various types of incision in the abdomen area, we'll take up this abdomen in two parts, part 2A and part 2B, just to avoid enlarging the video in duration. So let's start with the part 2, the abdominal incisions, and part A. So in this video, you must have remembered this table, and in this video we are going to discuss this midline incision, then paramedian incision, the cocker, the chevron, and supraumbilical and infraumbilical incisions, and pararectus incision. These are the incisions we are going to discuss in this video. As you all know, the mail ID, the web URL, the WhatsApp number, and Instagram, you know already all these things. So in this video, as far as the direction of the incision is concerned, basically we can divide all the incisions or almost all the incisions in three groups: the vertical incisions, the horizontal incisions, and oblique incision. So I will advise you, when we are discussing various types of incision, you can have this thing in your mind, whether it's a vertical incision or a horizontal incision or an oblique one, for your memory. So we are starting with the abdomen, and the first incision is midline incision. Here you can see just a topographical representation of human body, and although it is wide, but consider this dot as an umbilicus. Here you can see this midline incision. It could be only upper midline depending on the condition, depending on the indication, or it could be just lower midline. And sometimes this midline incision, here you can see this portion, this midline incision just surrounding the umbilicus, pairing the umbilicus, and again continuing a straight line in the midline. It could be a single large incision in the mid plane. So how it is important? It gives us a wide exposure for most of the organ that is present inside the abdomen. And another very important advantage of this midline incision is that whenever required, we can convert it into a T shape in order to get more exposure. Whenever required, it can be converted into T shape like this or like this whenever required. Right? So these are the basic important points of midline incision. Here you can see how it is placed, routinely used for exploratory laparotomy, and that's why here you can see this is also known as laparotomy incision or ciliotomy incision, and this is the most traditional one of various types of incision, very commonly used, right? And the size of this midline incision will depend on, it depends on the type of procedure performed, whether it is upper midline, low midline, how much the length should be. It depends upon the type of procedure, that is that are the type of procedure we are considering, right? So it could be small, and this midline incision can be applied anywhere on vertical linea elbow. If a smaller incision we want, according to the need, choose. You can choose, right? Then it may extend sometimes whenever required. It may extend from xiphoid process to pubic bone. Very long incision, usually in cases of procedures where we require wide exposure. The exploratory laparotomy, especially there is massive trauma is there, right? And mostly the most important advantage of this midline incision is the avascular plane. Mostly avascular plane here you can see, and that's why there is no risk to the blood supply usually, and very rarely the nerve damage may occur. Usually no nerves, major nerves is present in the midline, so usually nerve damage is not seen. Although scarring will be present, and it may be significant if performing multiple operations through the same incisional scar. Through the same incisional scar, scarring will be present significantly, right? And advantage of, again, another advantage of this midline incision is it provides best visualization on and as well as intra-abdominal access for various organs that is present inside the abdomen, and that's why it is very commonly employed for exploratory procedures as well as the trauma, abdominal trauma. Okay. Now after median incision, next comes the paramedian incision in abdominal area. Now what is paramedian incision? Here you can see this is umbilicus, and here you can see the placement of paramedian. Para means just by the side, and the median we have already discussed in the midplane, just by the side of this. That's why paramedian incision. Usually these paramedian incisions, they are given 2 to 5 centimeter lateral to the midline. Average we can take 3 centimeter, 3.5 centimeter, right? And it is usually given over the bulging convexity of rectus muscle, right? One of the very important disadvantages that it gives limited access to the contralateral organs. Suppose we have placed this paramedian incision towards the left side of the patient, over the left side, then there will be limited access to the liver or the, let's say, the right kidney or any organ that is just on the opposite side, right? Superior extension, here you can see the superior extension of this type of incision is usually not possible. Why? Because, or it is limited. Why? Because suppose we are extending it, then here is subcostal margin, so usually superior extension is not possible. Whereas in case of midline, you can see we can go up to this place also, and if required, and if we are joining it, the sternum is here, right? So midline, yes, superior extension is easily possible, but in paramedian incision usually not possible due to presence of costal margin. Another important disadvantage is this: there is atrophy of muscle, right? Atrophy of muscle medial to the incision. Why? Due to damaged lateral neurovascular bundles. Suppose the neurovascular bundles are coming through this place and we have placed the incision here. So the atrophy of muscle medial to the incision, the muscle fibers that is present at this point, they may get atrophy, right? So this is paramedian incision. There are few advantages. Whenever we want to expose the lateral viscera, The paramedian incision is always preferred as compared to median incision, as here you can see the lateral viscera we want to explore, and usually the average 3 centimeter lateral to the midline that is given. The skin subcutaneous tissue must be incised along with the anterior rectus sheath, and here anterior rectus sheath and rectus muscle is deflected laterally if possible to expose posterior rectus sheath if we are working above the arcuate line, and you all know that below the arcuate line this posterior rectus sheath is usually not there, absent, right? And after going through the rectus we can enter inside the peritoneum. Peripheral branches of the inferior epigastric artery usually will undergo ligation during paramedian incision placement, and the first advantage was for visualization of lateral viscera here, and the second advantage is it is more secure closure as compared to median incision due to presence of rectus abdominis muscle. It acts as a buttress during closure. Okay. Now after median and paramedian incision, next comes the Cocker incision. Now Cocker incision means also known as subcostal incision. Here you can see this is the xiphisternum, this is umbilicus, and this is right subcostal incision known as right side Cocker incision. Although we can apply it whenever required on the left side also here, right? We can apply it here also. Usually it starts at the midline 2 to 5 centimeter below the xiphoid process, extends downwards, outwards, and parallel to 2.5 centimeter below the costal margin. Here you can see. And there is excellent exposure of gallbladder and biliary tract, right? On the left side, if we are applying this Cocker incision, it is good for spleen exposure. So these are the indications for handling this gallbladder on the right side or for spleen exposure on the left side. A subcostal incision on right side of the abdomen is basically for gallbladder and biliary tree. It is located just inferior and parallel to the subcostal margin, the Cocker incision. And unlike the midline incision, it is not an avascular plane. Means the midline incision was an avascular plane. No vessel trauma, usually. But this Cocker incision is a vascular plane. That's why bleeding do occur, right? Bleeding do occur. Then extends to the anterior rectus fascia, the rectus muscle, while we are just giving this Cocker incision. These are the layers through which we are supposed to go. Then internal oblique, transversus abdominis, then transversalis fascia, and finally the peritoneum. And here there is interruption of blood supply of the abdominal wall, especially the distal aspect of the superior epigastric and the inferior epigastric, perforating intercostal arteries and external oblique perforatus. These blood supply could be interrupted during Cocker incision. It is associated with a slight increase in the pain during the post-operative phase due to cutting of the rectus muscle, and closure in a layered fashion by suturing and approximating facial layers we can close this incision, right? So important thing is in Cocker's incision again cutting of the rectus muscle is done. And there are other types of incision that is given over the abdominal area where we are going to cut the rectus muscle, and one of them was we have just discussed the Cocker's incision. And after Cocker's incision then comes a chevron incision. What is this chevron incision? You can see we have placed a right subcostal incision here, a left subcostal incision here, and then we have joined these two incisions, and this is xiphisternum and this is the umbilicus, right? This is umbilicus. So this somewhat it looks like a rooftop. So it is also known as a rooftop incision of double Cocker's incision, right side, left side, joining it. So it is also known as rooftop modification or gable modification, right? Chevron incision. In patients having broad costal margin, this chevron incision gives a, an excellent exposure of upper abdominal structures like stomach, right? Like liver. And that's why this chevron incision, there are various uses, and just to name them, the total gastrectomy if we want to go for, then total esophagectomy, and bilateral adrenalectomy, removal of adrenal gland, then extensive hepatic resection whenever it is required. So these are the important indications for this chevron incision. And this incision crosses midline. Not usually, it crosses midline of the abdomen, right? Then a subcostal incision, this chevron, that extends from mid to lateral costal ridge, and it across the midline travels to the contralateral side. And as I have told you already, that it provides valuable exposure for hepatic, pancreatic, the upper GI region, the adrenal glands, or sometimes renal surgeries also. This is another advantage. Through this chevron incision, simultaneously we have an access to the intra-abdominal cavity as well as the retroperitoneal space. Blood supply is interrupted obviously, and the bilateral superior epigastric vessels are interrupted. The abdominal wall will have collaterals from the perforating branches through the oblique muscles and inferior epigastric. That's why even after giving chevron incision, the patient will not have any devascularized flap or tissue, right? Why? Because this abdominal wall will develop collaterals. From where? From perforating branches through the oblique muscles, then external and internal oblique muscles, and inferior epigastric, right? But this is very important point. Suppose we have given a chevron incision in any patient, he recovered, and let's say later on after 1 or 2 years, if there is another surgery over this patient after a chevron, and if suppose that incision is going through the lower abdominal wall, there may be an interruption of the inferior epigastric in this scenario and the middle of the abdominal wall, and that's why it will develop a least amount of collateral blood supply and finally ultimately be devascularized tissue. So devascularization is possible after chevron if another incision is being given through the lower abdominal wall in the same patient. Important point. Then after chevron, the supra and infraumbilical incision. Supra and infraumbilical incision. These supra and infraumbilical incision, as you can see here, this one is supra and this one is infraumbilical. Basically used for umbilical hernia repair and even during minimal access surgery for laparoscopic first port placement. That's blind port placement routinely. Right? Whereas in minimal access surgery, if the umbilical area is not available for first port insertion, then through the palmar point, we create pneumoperitoneum, and when then under vision, we can put other ports also. We'll discuss in some other video this minimal access surgery part. Then supra and infraumbilical incisions, these are used for access into the peritoneum, right, through the tissues surrounding the umbilicus, right. Due to the umbilical stalk present, it is unwise to incise directly through the umbilicus, right. So transumbilical incision should not be used, okay, due to presence of umbilical stalk. and that's why the incision around the umbilicus must root around it, not through it. Okay. Then infraumbilical incision may be vertical sometimes, like during minimal access surgery for placement of Hassan's cannula along the linea alba, and this is an avascular plane. So infraumbilical for minimal access. Sometimes the incision may be transverse, for example for repair of open umbilical hernia, the open repair of umbilical hernia. Then for supraumbilical access, this supraumbilical incision is used for access into the peritoneum for again open umbilical hernia repairs whenever there is presence of previous incisions in the infraumbilical region. Suppose infraumbilical region is scarred and there is an umbilical hernia, so obviously we'll go through a supraumbilical route. And if the transverse incision is made, it is recommended that we must use a tight U or inverted omega shape around umbilicus to keep the future scare hidden. Sometimes it can be curvilinear also to match the natural curve of umbilical ridge for better cosmesis, right? It is important not to devascularize the umbilical stalk or the thin umbilical skin by going through transumbilical route, or so avoid any transumbilical incision, right? And if an incision is made along the umbilical ridge, then there must be enough untouched skin on the opposite side of the incision to provide sufficient blood supply. So blood supply is another important issue while using the umbilical ridge. After this supra and infraumbilical incision, in this video, probably the last one is the pararectus incision. This pararectus incision is also known as cameral battle incision. Cameral battle incision, right? Usually, here you can see this is umbilicus and this one is pararectus or cameral battle incision. This is usually given parallel to the rectus lateral border. One of the disadvantages is it is having a very small opening, and whenever we want to extend it longitudinally, it leads to multiple segmental nerve damage, and finally this multiple segmental nerve damage will result in the post-operative muscle weakness. Here you can see, right? So pararectus is an incision that is made through semilunar line laterally to rectus abdominis muscle, and it is the important indication for using this pararectus incision as a Spigelian hernia, or if modified, sometimes it can be used for an ostomy also. If incision is made circularly and rectus abdominis is not incised but retracted, then incision can be carried through the peritoneum to retrieve intestine for ostomy formation, like in ileostomy or sometimes colostomy also. This is again a very important thing. How inferior or superior the incision is located means the site of the incision, pararectus incision, is very important. Why? Because it is going to affect the blood supply. If very inferior this one, it is going to affect the blood supply from inferior epigastric, or the vice versa, the superior epigastric, or sometimes in watershed zone between the two main arteries. So again, this pararectus will affect the blood supply of anti-abdominal wall. So take care while placing it. And that's all in this video. And the second part, rest of the abdominal incision, we are going to discuss. Till then, take care. Bye bye. See you there.